and red wine's a place to be at the moment. But yeah, lots of work happening on the mountain now. So yeah, should be a good final day on the slopes for those that have to go home on Saturday morning, unfortunately. We have had a few people just mention that the e-learning link is not working for them. So what I'll do tonight, I'm just going to send out a new link to everyone. With the e-learning, just a reminder, that's open up until June. So there's no rush to complete that at all. The idea behind that is that it's really just an opportunity for those who like to get a little bit of extra PD in at some stage throughout the conference week, or when you return home when you have a little bit more time up your sleeves. So feel free to check that out, have a look, but no rush at all without being there till June. Mentioned a little bit about it last night, but I'll just mention again, tomorrow evening the closing party at Pirate Man. So 7:30 start. Please bring your lanyards. If you lost your lanyard already, don't stress. We will have a list on the door, but it just means you can walk straight in. There isn't a huge amount of space there. For those who have already been to Pirate Man, you probably know what I mean. But I would encourage people to leave valuables at home, just because very non-malicious, but lots of the jackets look the same, and many years we get a lot of emails on Saturday morning of people who've lost passports, phones and wallets. So to save chasing all those up, I recommend bringing or leaving any of those valuable ones in your hotel room. We will have free-flowing drinks from 7:30 to 9:30, cash bars available after 9:30, and the drinks will be around 300 to 400 yen. So you don't need to bring much money, just a few coins in your pockets and you should be right for the night. If anyone does have any questions, unsure about anything, please feel free to hit myself or Dylan up. We still have a few little registration packs and certificates that are yet to be collected, so even if one of your colleagues or anyone like that you know missed out, just see Dylan in the sessions. I think that's enough for me for now. So tonight we've got Red to kick things off, so let's hear it for Red.
Hello. Hi everyone, my name's Red Wiard. I am a registered nurse from Brisbane, sunny Queensland. I've been a registered nurse for about 7 years now, and for the last 3 years I've been predominantly working in the mental health space. I work with veterans for a company called Open Arms Veterans and Family Counselling. Has anyone heard of that organisation? Awesome. So I'll be telling you a little bit about myself and the work that I do. Okay, so overview of today's session. When I say ADF, I'm referring to the Australian Defence Force. I wear a couple of different hats. So I'm also a nursing officer in the Army Reserves. I work as a case manager for Open Arms, who supports veterans. And I also do some casual agency nursing shifts to keep up my clinical skills. So it's never boring. I'm always finding something exciting to do. I'll tell you a little bit about Open Arms, the history and the purpose of the organisation, some general mental health statistics for Australia and also for the veteran community. I'll go through 3 case studies. These are real clients that I've worked with that'll just give you a bit of an insight as the types of treatments and support that we can provide for them. The risk assessment and safety planning section has a little bit of an interactive part for this presentation. So I'll get you guys to go onto your phones and go to menti.com, and there'll be a code that I'll give you later on in the slides, and it just gets you guys to put in some answers which will encourage some group discussion. We're going to talk about self-care and sustaining resilience. So every healthcare professional should practice their self-cares, and one thing is not going to work for someone else. You just got to find something that works for you to help you de-stress and reset to get back to doing your job professionally. And finally, I'll end on a little bit of a sombre note. I'll be talking a little bit about the Royal Commission into Defence and Veteran Suicide, something that's very close to my heart. So this is a little bit of my background. I did my nursing and paramedic degree, and while I was a student at ACU, I was a volunteer with St John's Ambulance. And so this just gave me a little bit more practical skills to get some hands-on experience. That picture at the top left is from the ECA, or the Brisbane Royal Exhibition Show. I really had my heart set on being a paramedic, but then I ended up in nursing, and that was in my grad year in the interventional radiology suites at the Royal Brisbane and Women's Hospital. So I currently do casual shifts there in HADS, which is the Hospital Alcohol and Drug Service. And part of my Masters of Mental Health Nursing, I majored in drug and alcohol and counselling with, in particular, motivational interviewing and cognitive-based therapies. This picture is from my March Out Parade when I joined the military. Does anyone know what this bottom picture is? Yeah, that is the Arthur Gorrie Correctional Centre. It's a remand centre, a prison in Wacol in Brisbane. So I worked there for about 7 months. It wasn't a very nice place to work, but that was where my interest in mental health started, because there was a lot of inmates there that, you know, probably had a lot of undiagnosed mental disorders, and if they were medicated, maybe that would reduce some of the assaults and the behaviours, the self-harming and stuff like that that was happening. So it was a very stressful place to work, but because of that, you know, I now work in the mental health space. And this picture here is at the Australian College of Mental Health Nurses Conference last year, and I'm very proud to say that I'll be presenting there as well later this year. Always like to start off with a meme, but I got no laughs. Okay, so a little bit about Open Arms. We provide free counselling for individuals, couples counselling, and for families for children 5 years or older. Is anyone in the audience here a current serving member of the Australian Army, Navy or Air Force? Ex-serving member of the Australian Army or Air Force. Awesome. Is anyone the spouse of a current or ex-serving member? Yep. Is anyone the child of a current or ex-serving member? Yep. So everyone that put their hands up then, you'd all be eligible for Open Arms, free counselling service and all of the group programs. So as part of our training, we have a 4 weeks of induction where we're basically learning the recovery-oriented practice for complex needs clients. Myself as a case manager, I work with some clients that have some, you know, high needs, both social and emotional, and, you know, with their mental health, they need like admissions to hospital for certain treatments and things like that. And we're all trained in TIC or trauma-informed care. We offer a crisis accommodation program, or the CAP. So this entitles eligible veterans and families for up to 5 days of accommodation that's paid for by us to get them out of a mental health crisis, a domestic violence crisis, child safety, something like that. And then the case managers look at something that's more longer term to get them into something suitable, to get them away from whatever risk that they were seeking at the time. We do psychiatrist referrals for mental health diagnosis and treatment. We don't do psychiatry referrals for ADHD or ASD. It's usually just to, you know, someone showing symptoms of a mental illness. They can get 5 sessions from a psychiatrist that's paid for by us. And the group programs, the most popular one is the mental health first aid, and that looks good on anyone's resume. The other most popular one is the ASSIST, so that's the Applied Suicide Intervention Skills Training Program. Other ones include workshops for clients that may have depression, anxiety, post-traumatic stress disorder. There's ones about sleeping better, stress and relaxation, pain management. There's relationships groups, and they're all listed on our website, which is openarms.gov.au. So Open Arms was previously called VVCS, or Vietnam Veterans Counselling Service, and it was started in 1982 by Vietnam veterans. In 2017, it was rebranded to the name of Open Arms Veterans and Family Counselling. We received a lot more government funding because they realised that this special population of people, you know, really needed a lot of help, especially if they've been on operational deployments. They come home and they're just not getting the support that they needed at the time. In 2020, we developed our peer program. So that is a less clinical approach to support our veteran community, where someone may be an ex-serving member that works as a peer, or they might be like a spouse of a serving or ex-serving member. They catch up with them for coffee. They might help them with their DVA claims, so the Department of Veterans Affairs. Just helping them get that social connection if they've been a little bit isolated. In 2020, March 2020, we all know what happened around that time. So our 1-800 number went to a 24/7 call centre. So people could ring up that number if they just needed a little bit of support over the phone, some crisis intervention, some de-escalation, and all of our clinicians that work on that hotline, they are either mental health nurses, social workers trained in mental health, occupational therapists, or clinical psychologists. So I started in that role before I became a case manager. In November of 2020, the Safe Zone Anonymous Hotline was developed, so that's a different number that these veterans can ring. They don't have to say who they are or where they served. They might just want to have a confidential chat. They might want to talk about something that's happened in the media that's defence related, but they just want to remain anonymous. In March of 21, we developed the PAD program, or Psychiatric Assistance Dogs. So quite a few of my clients, they have a dog that's been fully trained to be an assistance dog. I think it's around $20,000 or close to $25,000 that goes into the training for these dogs to work with these clients. So it's not a cheap program. In April 21, Mending Military Minds program developed. So that is for veterans over 65 years of age that have a neurocognitive disorder, and DVA would pay for them to go through all of their cognitive assessments, in the public hospital system. That's fully paid for. And in January 22, so that's our most recent program that was developed, was the parenting program. So a lot of defence members, they get their postings every 2 or 3 years all around Australia, and their children may have some behavioural challenges that they're experiencing. So these parenting programs are just to provide a little bit of extra support for them, or parents that have a child that has ASD or ADHD. So this is just a bit of a demographic that shows you the population and the number of clients that we have in these particular areas. As you can see, Queensland, is the largest amount of clients that we do have. And then down the bottom is just like by age down there. So 70 to 79-year-old veterans, 75,000 clients, or thereabouts. So these are just some general statistics about the mental health burden in Australia. 3.6 million people aged 16 to 85 years old experience a mental illness. Less than half will access treatment. $40 billion a year spent on the mental health budget in Australia. That's a lot of money. Suicide is the leading cause of death among 15 to 44-year-olds. This was from the AIWH website. I think Joe spoke about this last night to say that, this is a crisis, it's a huge amount of people. And 65,000 Australians make a suicide attempt each year. A lot of these numbers aren't actually reported, so the number would be probably higher than that, but they're not recorded in the statistics. So some ADF mental health stats. Anxiety disorders are the most common, with females more than males. Post-traumatic stress disorder, higher in ADF males than in the general population due to the nature of their service, especially if they've had operational overseas deployments. 91% of ADF personnel have experienced at least one traumatic event compared to 65% of the general population. So that's quite a difference there, isn't it? Mood disorders in ADF males were higher than the general population males, and 1 in 5 who have served in overseas conflicts suffer with a mental disorder. So this is just going to go through some of the clients that I have looked after. We'll start with a 33-year-old ex-serving member. He was in the Infantry Special Forces for 10 years, pretty much joined straight after high school. He's had multiple deployments to Iraq and Afghanistan. He's single, he has no children, he has a history of homelessness and now lives with his brother. So he has a diagnosis of bipolar type 1, so he experiences very manic and then depressive episodes. When he gets manic, he goes on spending sprees, and he was in receipt of about a $200,000 payout from DVA due to his mental and physical injuries that he sustained while serving. He blew the whole lot. So he became homeless, he had no money, he developed a substance use disorder. He drinks, he is an intravenous drug user using methamphetamines, and when he goes into these really depressive states, he becomes very suicidal. These are his other comorbidities up there. He has experienced these alcohol withdrawal seizures in the past, but it was our job to get him the support through counselling, complex needs, liaising with psychiatrists and DVA to get those medical problems looked after. He now has an exercise physiologist that he works with for his back injury. He has a psychiatrist that he sees for ongoing treatment, and he's been into rehab, I think, 3 or 4 times. Unfortunately, with people that do have the substance use disorders, they can relapse and then go back to sobriety and relapse again. But this is the longest time that he's been sober so far, and I think it's around 4 months. So well done to him. That's just an idea of the types of services that we use for our organisation that can provide him with extra support. Case study 2, so we've got a 34-year-old female. She's the ex-wife of an ex-serving member, and she's separated from her husband 6 months ago. So Open Arms still supports ex-partners of serving or ex-serving members for up to a period of 5 years, but indefinitely if they have shared children together under the age of 18 years old. So they do have 3 kids, age 5, 7 and 10. And 2 of her oldest children have special needs, so they can have some quite challenging behaviours. She herself has no formal mental health diagnosis, but she does have some depressive symptoms. She's had a lot of changes within the last 6 months with her separation and now being a single parent. So unfortunately, she was the victim of domestic violence. She called the 1-800 number in a crisis. She'd locked herself in the bathroom. Her husband had physically assaulted her. She said that she looked in the mirror and she had blurred vision and her speech was slurred. She had broken teeth in her mouth and her husband was banging on the door trying to get in there. So we said, don't get out. You need to stay in that bathroom to keep yourself safe. We had to call police and ambulance services to go to her house to de-escalate that situation. And as part of our duty of care, we had to make a report to the Department of Children's Services because these children have been witnessing this violence on multiple occasions. So she now has a case manager through 1-800 RESPECT, the Family and Domestic Violence Service, and she also has a case manager from DOCS. So what we did for her, we gave her some individual counselling, some family counselling, so for her children as well. She utilised the CAP, the Crisis Accommodation Program, so we got her into a safe space for her and her 3 children. She's done a couple of our group programs here, Beating the Blues for our clients with depressive symptoms. She's done the mental health first aid, the parenting program, and she utilises the 1-800 number when she needs a bit of support. Case study number 3. This is one of my favourite clients. I love working with the older Vietnam vets. He's a 76-year-old male, Vietnam War veteran. He lives with his wife who's 72 years old. They've been married for 50 years. He is a DVA gold card holder. So TPI is total permanent incapacitation. So after his deployment, he was unable to work due to mental and physical injuries. So he gets a veteran's pension, and he has done since, I think, he was quite a young male. He has a diagnosis of post-traumatic stress disorder, anxiety and depression, but it is quite well managed, and he's very help-seeking and is very receptive to treatment, and always he's happy to engage in what we offer. He's got a couple of comorbidities there: hypertension, diabetes, sleep apnea, hearing loss, bilateral knee replacements, tinnitus. He's got a few different medications there. He does get night terrors, so he uses prazosin there, Panol-Ostedo for his joint problems, and he uses diazepam as a PRN mainly to assist with his sleep or when he's feeling super anxious. So he utilised our services, the MMM program. He got the full neurocognitive assessment. He has a psychiatric assistance dog. He utilises one of our peers, but he didn't really want to do counselling face-to-face. He just wanted the peer just to have a bit of a yarn because, he's a bit lonely. It's just him and his wife on their own, and he's quite a sweet man. And he utilises the 1-800 number for 24/7 support as well. Oh. So I'll get you to go onto your phones now, log on to menti.com, put in this number. If you can't see it up the back there, the number is 51975880, and you can put up to 3 answers. You can put one if you really want, or two or none, but I'd like you to put some. If you can just put in your response what factors can contribute to someone's risk of suicide. So I'll just give you a minute to pop those answers in. Is that coming up? Is that coming up for everyone on their phone? Yep, awesome. And they'll just pop up on the screen once people start putting their responses in. The number is 5197 5880. Some good answers there so far. And the words that come up with a bigger text is what more than one person has put in that answer. So we've got isolation, depression, substance use, previous attempts, age, family history, loss of spouse, financial stress, nobody knows, alcohol and drug misuse, relationship breakdown, partners, divorced, trauma. Yeah, really good responses there, guys. All right, it stopped moving. Everybody's put something in. That's really good. Age, disability, male, gender, family violence. Ooh, what else we got there? Yeah, that's good. Oh, yeah. Okay, this might be a little bit hard for the people up the back to see, but the Safe Side framework is something that we use when we do our risk assessment at Open Arms. So there's many different factors that can contribute to someone's risk of suicide, and every conversation that we have, whether that's on the phone or via face-to-face counselling, we have to check this with our clients because, if they say yes to some of these things, then we need to action that and we need to provide the supports that are going to prevent them from doing this. So up here we've got someone's strengths and protective factors. So I'll just read some of them out if you can't see up the back. Social supports, strong cultural connections and identity, evidence of problem solving and coping skills, active participants in treatment. So if they're willing and able to come along to their sessions, that shows help-seeking behaviours. Helpfulness, hopefulness, children present in their home. So I find often parents, if they do have a young child at home, that might be their only protective factor when everything else is, gone to shit. Life satisfaction, fear of social disapproval, or fear of suicide or death. So those are the strengths and protective factors. Some of the longer term risk factors here, we've got a psychiatric diagnosis, especially if comorbid or chronic. Yep. So a lot of you guys said that already. Childhood trauma, family history of suicide, a recent peer or public suicide, combat experience. So, our defence members, a lot of them have that. Demographic considerations, same-sex sexual orientation for men or male gender, especially I think it's around the 20 to 35-year-old males. Cultural considerations, potential isolation, language minority and the LGBTQ populations. So then we go into someone's impulsivity and self-control, which is a contributing risk factor. Do they use substances? Do they use alcohol? Are they impulsive, reckless? Do they show aggression when they're under the influence of these substances? That would increase their impulsivity to harm, self-harm. Previous suicidal behaviour, other stresses down here. So a lot of you guys mentioned financial, relationship problems, stressful loss or rejection, so loss of job, loss of identity. Often sometimes when people leave the military, they may have served for like 20 years and that was, you know, how they identified themselves as a sense of being, and when they lose that, their risk can go up. Feeling alone, isolated, trapped, humiliation or social rejection. And then down here, the symptoms or recent changes. So is someone really anxious, panicked or fearful? If they're hopelessness, they literally can't see a light at the end of the tunnel, unexpected change of some sort, or do they have hope for their recovery? So yeah, that's just an overview of, you know, what you guys put in your responses. So that was really good. So this is just going over the safe side model of CARE, and everyone loves an acronym in defence, and CARE stands for connect, assess, respond and extend. So you need to connect with the person. Obviously you're not just going to go ask and be like, are you suicidal? Because if you don't have a therapeutic relationship with them, if you haven't built that trust with them, they probably won't answer truthfully to your questions. So you need to connect with them about some sort of life experience and let them know that you're committed to their recovery. Assessing, so going through those areas of risk that we just discussed, putting it into a prevention-oriented risk framework. So each client is going to be very individual with, you know, what risk factors they identify with. Respond, using evidence-based treatments, safety planning, removing the lethal means if they have access to weapons, ropes, knives, medications, things like that. You know, just talking to them about how to reduce those means for them to keep them safe. Using the least restrictive environment. So under the Mental Health Act, you know, we have sort of moved away from physical restraint now. You know, we do need to use medications at times if someone is like physically aggressive, especially to other staff or other patients in hospital. But we always try and use the least restrictive environment possible to give that patient a little bit more dignity. And extend. So this is just liaising with other services, making sure you're doing follow-up assessments. If you say you're going to call this client at a certain day or time, make sure you do that so that person feels that they're not being neglected or left out, because a lot of these clients, they have some form of trauma and they often feel abandoned from, you know, past childhood experiences or other means. And that's just an overview of the CARE model there. One thing I'd like to point out was the risk status and the risk state. So they're two different things. So someone can score high on a risk status if they have a past history of a suicide attempt that is relative to others in a stated population. And then their risk state is like how they are now. So did they try and attempt suicide last week, or was it like 10 years ago? So that, you know, depending on, you have to ask these questions in a particular way to assess their risk state and risk status. I'll get you to log back onto Menti again, but before you put in the number, I need to change something on my PowerPoint. Okay, so what does self-care look like to you? Has everyone got that number, or did it disappear? Okay. Oh, yep, so the number is 5197 5880. So just, I'll give you a minute to do that. Pop in, what does self-care look like to you? Lots of people put sleep and exercise. I like those too. Time off, work-life balance, lots of holidays, relaxing, socialising, time for joy, time away from work, Dungeons and Dragons. We've got some gamers there. Being outdoors, personal time, hot showers, time with family, footy, being outdoors, wine, yes. Mindfulness, catching up with friends, clear boundaries, being outdoors, times with loved ones, putting yourself first. Yeah, that's right. So if your cup's half empty, how are you meant to fill others, right? Food, debriefing, gym, own time. Lots of good responses there. Chocolate. Yes. Snowboarding. That should have been like the biggest one. Drone time. Reading, relaxation, swimming. Onsens. Yes. I had one of those today. It's awesome. It's pretty good. Thanks, everyone. Yep. So these are some of the things that I like to do for my self-care. I love riding motorbikes. I love being outdoors. I love lifting stuff at the gym, doing my meal prep. I feel like if I've cooked nice, healthy, nutritious foods for the week, then I've set myself up and I don't have to be in the kitchen every single night of the week. Snowboarding. I love going for a float. Does anyone else do that? Float therapy, magnesium. It's a huge pool where you go in naked and you have earplugs and it's sensory deprivation. So it's no sight, no sound, and I just fall asleep in there. So 1 hour in a float is equivalent to, I think, 6 hours sleeping in your bed. So after night shifts, I love doing this. It's really good to recharge. Time with my partner, Jaden, my cat and my dog. So everyone's going to have different things that they do for their self-care, and that's just, a few different ideas to help make sure that you're practicing these things, especially if you have like a really traumatic job or something that you do attend. Debriefing with your colleagues or with your partner or whatever is really important so that you don't burn out. Okay, last topic of my presentation. We're just going to be going over some of the statistics with the Royal Commission into Defence and Veteran Suicide. Has anyone been following along with this at all or seen it in the news? Yeah. So they're still doing all the hearings around the country. I think the next one is in Perth in May. They've done them in most major cities in Australia and some rural areas as well. I just put this trigger warning here that we are going to be talking about suicide. If this is triggering for anybody, I won't be offended if you do need to leave the room at all. So back to Menti. Let me just reset my thing. Click exit. How do I get that? Oh, there it is. Okay, so the code, if you can please pop in 51975880. Have you known someone who has died by suicide? Yes, a close friend or family member. Yes, an acquaintance, or no. That number is 51975880. Surely there's more than 50-something people in this room. I know a couple of you haven't put your numbers in. I did this presentation to the 2nd Health Battalion, which is where I currently parade as a nursing officer. And this was at the end of last year. Unfortunately, we did have 2 of our members that did take their own lives. Look, it's a really difficult conversation that, I still get a little bit choked up when I talk about it because sadly I'm on the yes. 2 of my very close friends passed away in 2020. It's pretty close to my heart. So these are just some of the statistics about the Royal Commission. 41 Australian soldiers were killed in action, or KIA, in Afghanistan, and more than 10 times that have died by suicide since coming home. So just let those numbers sink in for you a little bit. From 2001 to 2019, 465 certified deaths by suicide. That was on the Royal Commission on their website. So all of these stats are found there, and I've been following quite closely with that. These are all the submissions that have been received, over 3,000 phone inquiries where people might ring up and ask a question about submitting an inquiry. If they have known someone who has died by suicide, they ask, how can I set a submission? They might have some evidence that can be used, and then they investigate all of that to try and make some changes to mitigate that risk in the future. There's been 312 sessions held around the country, 243 witnesses at these hearings, and anyone can attend. If you've made a submission or a family member, if you want to be there for support, you can attend at these hearings that are across the country. And there's been 96,000 live stream views. So it is all up on their website if you want to watch any of the hearings. So back to the stats again. On average, that's one veteran every 2 weeks that takes their own life, and 9 Australians a day die by suicide, and 7 of those are men. One thing that I wanted to note is that when we talk about someone taking their own life in the mental health world, we say they died by suicide. We don't use the word commit suicide. The reason for that is commit has a negative connotation to it. It's like saying you committed a crime or something like that. So that's the same when we talk about people that have substance use disorders. We don't call them drug addicts. We say they use drugs of addiction or a substance use disorder. Okay, so these are more statistics from the Australian Institute of Health and Welfare. And this one is showing that ex-serving members of the Australian Defence Force, they're at a higher risk of suicide than the general population of Australian males. So under 25 years old, they're 1.9 times more likely to die by suicide. And for the 25 to 34-year-old age group, they're 1.4 times more likely. This table from the AIWH is showing ex-serving ADF males who died by suicide and the total number of ex-serving ADF males by service. So by Army, Navy and Air Force. Army is the most superior force, but we also have the most members and sadly the most suicides in that area. This table is showing ex-serving ADF males who died by suicide and the total ex-serving ADF males by time since separation. So that's when they left the Defence Force. If you just look at the number of years since separation, so in that 1 year post leaving the military, there was, from the year 2011 to 2018, 10. Number of years since separation, 1 to 5, so a little bit longer since leaving the military, that goes up to 30, okay? And then 5 or more years since separation, it goes up to 33. So usually from that 1 to 5 years post leaving the military, their risk is a lot higher. They may have lost their purpose, their sense of identity. They may have realised that they've developed a mental illness, and there's a lot of shame and stigma that's associated with that. While their mates are still in the army, going on deployments or, talking about their career and things like that, that person that's left doesn't have that anymore. So these are some of the positive changes from the Royal Commission. With the Department of Veterans Affairs, they've employed 1,500 new staff members to help with the backlog of claims. I know a lot of mates that are still trying to go through their claims process for injuries that they suffered 10 years ago or more, and there's like a 2-year wait period. They've now tried to reduce that back down to about 6 to 9 months. So yeah, it's still pretty significant, especially if you're paying for treatments like physio, you're going for remedial massages, you're having to get a lot of medical treatments that you're paying for out of your own pocket. Hopefully DVA will pick up the slack there with all these new staff members that they employed at the start of this year to help eliminate that backlog. The administrative process for ROI, or the release of information. So whenever someone makes a claim for their mental or physical health through DVA, they have to get all of their medical records from wherever they served. And if it was a really long time ago, there's quite a process that they have to go through to get that information. All of the DVA staff are now trained in trauma-informed practices because clients might get quite emotional when they're trying to access this information. They're getting very frustrated due to the long wait times and things like that. So they need to learn to speak respectively and in a calm manner to people that ring up and they need to talk about this sort of stuff. There's a huge budget here for psychiatric assistance dogs, which is something that I'm really pro because dogs are awesome. And they definitely have a lot of therapeutic benefit to our clients with PTSD. Again, bigger budget there for medical treatments that are now being covered and protections for persons that are still serving in the military that want to make a submission. So I've just popped up here a couple of free resources for your mental health. Some phone apps I recommend to my clients are Calm, Smiling Mind, Insight Timer, High-Res and Swiss 8. These last two were developed by veterans and they talk about the 8 pillars of strength. There's a lot of mindfulness resources in there, breathing exercises, grounding techniques, that sort of stuff. And that's all free to download. That's our number for Open Arms. Number for Lifeline just for the general population if you don't meet Open Arms eligibility. askizzy.org.au, there's a website and also a free phone app, and that one's really good to recommend people to for housing, food shelters, domestic violence support, legal aid or alcohol and other drug services with detox facilities. The Employment Assistance Program or EAP, so any Queensland Health employees here? Yes, a couple. Don't want to admit it. Yeah, so you get 3 sessions from EAP counselling that can be extended for another 6 sessions through your time with Queensland Health. This website here, 42for42.org, is a whole list of ex-service organisations from coffee shops to there's leather making workshops and social connections, surf shops, anything that's veteran owned or operated or that has some connection to the military. That website there is like a one-stop shop for everything for veterans that want to engage with other military personnel. And Kookaburra Kids, these are free programs for troubled youth. So I think the minimum age is 5 and it goes up to 17. I often recommend, as well as the parenting program, this one to some of our clients that have challenging behaviours from their children. They do group programs and things like that. So that's everything, and I've popped my details up there. If anyone has any questions, I'm happy to talk to you now, or you can email me. Does anyone have any questions? Oh, sorry. Yes. What is your question?
It's all right. I speak quite loud, so it's fine. So my question is, if anyone is getting access to your DVA line themselves and they're not a DVA person, if they're in a crisis, what does your DVA line do? Do they just go, sorry, this isn't our problem, and refer you back to Lifeline, and then if that person's in a crisis, they're kind of in that shit position where they just don't call anyone, or do you directly sort of link them into Lifeline?
Yeah, look, we don't get them off the phone straight away. Just for others up the back that didn't hear, it was what if someone uses that DVA line, they're not eligible for the service, they're in some form of crisis, but they're not actually eligible to access our service. We would still have to do a risk assessment and a safety plan. We might have to get emergency services to ask them where they are. Do they need an ambulance if they're at risk of self-harming? So we would provide that duty of care to them. We would usually send them a text message that says, here are the list of numbers that you can call, like Lifeline, Beyond Blue, the suicide callback service. We have a whole list of cheat sheets and stuff that we could refer to, but immediately while we have them on the phone, we need to ask where they are, their risk questions, and then we would provide police or ambulance if that was required. So yeah, we wouldn't just be sorry, see ya, you're not eligible. Yeah, it's we do have that duty of care to be able to provide that. Yeah. Any other questions? Okay, thank you everyone, and those are my references.
And thank you to Red for providing such a great insight to the awesome work that you and your colleagues do. So, break time. We've got about 5-10 minutes, so I think there's a few pieces of sushi left for those those that are still hungry, some wine, got the glasses, and then we'll come back here to kick it all off again. Cheers.
Whew, I'm hot now. Huh?